We're now live, Chair.
Thank you. Okay, good morning, everybody, and welcome to this meeting of the Health and Wellbeing Board. Before we start on the formal agendas, I just need to flag up for people that unfortunately there was an issue with the papers for this meeting not being published on the council's website as they should have been. Apologies from those responsible for that. I think the advice we're taking is that we should go ahead with the meeting. We will publicise the papers and a link to the live stream after the meeting. I appreciate it'd be quite challenging for everybody to rearrange the papers at that short notice. Secondly, apologies that childcare is going on, so no, please leave the mouse alone. Thank you, Eliza. So we may get the odd unexpected contribution. Okay, so item 1 is substitutes and any apologies. Kirsty, do we have any to report?
Diane's parking this
morning. Sorry, hello, it's Diane here.
Sorry, Diane. Okay, over to you. Yeah.
That's okay. You've got a substitute for Karen Jackson for Locala, and it's Tim Fox. Not sure I've seen his name come up.
Yes, he's there.
But that's what I was advised, with apologies from Karen.
Thank you.
Yeah. Thank you. That's it.
Thank you. And I think I'm seeing Sean there as well. Are you covering for Ian this morning?
Yeah, just for the first part, Councillor Swift. He should be joining the meeting at 11 o'clock.
Thank you. And I'm aware, Anna, I know you need to leave at 11:30 as well. Okay, item 2, if I can remind members to if I can remind members to declare any yeah, I can't say it this morning. Any disclosable interests that you may have on items as they arrive. Item 3, there's no private items, so we don't need to exclude the public for anything. Item 4 is the minutes of the meeting held on the 12th of August. Thank you, Stephen, for chairing that in my absence. Can I just check if there are any points of accuracy that anybody wants to raise? I'm not seeing anybody. If I could just ask if people can, incidentally, if you're able to use the raise hands functions if you want to come in, because I can't see everybody on one screen. So just mention that. Okay. So I'll take that as consent then, and we can sign those as a correct record. So item 5 is question time. I suspect with the non-publication we don't have any, but if I can just check, Diane, that we don't have any questions.
I've had no questions. I did double check that this morning. There's no questions being sent.
So,
but there won't be if they weren't published.
No, although the date was there, but yeah, okay. Understood. So we'll move straight on then to item 6, which is the Health Inequalities Stock Take and Progress Report. And I think, Anna, I think you're introducing this as well, aren't you?
I am, yes, thank you very much. For those people who don't know me, my name's Anna Basford. I'm Director of Transformation and Partnerships at CHFT. And this morning I'm presenting a report to the board to provide an update on the work that's been undertaken to address the health inequalities impact of the COVID-19 pandemic on our Black, Asian and minority ethnic communities. So members will be well aware that in April 2020, locally and nationally, evidence emerged about the disproportionate impact of the pandemic on those communities. And in response to this, Calderdale Council, alongside all system partners, engaged with those local communities in Calderdale to listen to their views and experiences during the pandemic, and to gain and gather insights into how we could work together as a system to better support those communities. As a result, a BAME action plan was developed and it was presented to the Health and Wellbeing Board in July 2020. The plan sets out 10 goals, and each goal has a named lead from across a range of different organisations with responsibility for taking forward those actions, working with our local communities. The 10 goals within the Calderdale BAME action plan do align and have been mapped against the wider West Yorkshire action plan in response to addressing inequalities that have arisen during the pandemic. And they do align well to the 4 themes that West Yorkshire is pursuing as a whole in relation to improving safe access to work, ensuring system leadership, ensuring that we use population health planning methods that will address those inequalities, and also that we reduce inequalities in mental health. The report presented today is very much intended as a process update and to confirm the continued focus and oversight that's been put in place to monitor and track progress against the plan. A system-wide group has been established. It has representation from all partner organisations, and it has been meeting regularly. And the actions that were agreed back in July 2020 have continued to be reviewed and modified to respond as necessary to the different waves of the pandemic that we've subsequently experienced. So today's report is to really confirm that ongoing commitment, to describe that process of oversight. What the report today doesn't seek to do is to provide a full update around the and so what impact of those actions had. And that's quite deliberately the case because the people that need to advise what impact these actions have had are the local communities themselves. So today I'm asking the Health and Wellbeing Board to note the process and systems that are in place, and also to ask the Health and Wellbeing Board to agree to provide an amount of time at a future meeting where members of those local communities can be invited to come and speak directly to the Health and Wellbeing Board about what impact that's had and what their experiences currently are as we continue to live through this pandemic. Thank you.
Okay, thank you very much, Anna. Any questions or comments for Anna on the report and presentation? Okay, I'm not seeing anybody, so we're asked to agree to.
Sorry, Chair, I put my digital hand up. Yeah,
that's just seeing it. Okay.
Yeah, so this is obviously a paper about the process and the governance, etc., and the progress that's been made. But in terms of the actual challenge, have we got any indications? I know you talked, Anna, about a future meeting, but there's an immediacy of this problem, and there's already a burden of morbidity and mortality that's affected these populations over the last 12 to 18 months. So it is an urgent issue. Do we know that we've got evidence that we're making an impact already?
Thanks, Anna.
We do know that we have been in preparing feedback from local communities. We do know there are some really positive examples about the support that people feel has been provided or has to address those inequalities. So a key example that's often referred to is the work particularly that's been done with taxi drivers in the local area and supporting them in their workplace. In terms of those case studies that have been compiled, as I say, they're being put together into a video which we will be able to share around those stories. I know I'm not sure that Debs is with us this morning. Debs has advised that we do know that in response in the early stages of the pandemic, we did see a direct impact around some reduction in prevalence in that area. But you're absolutely right, Stephen, as we know, it's an ongoing and continued commitment that's needed. And there's no intent to say that the issue has been fully resolved and addressed. We had an action plan, the actions is completed. It is an ongoing piece of work.
Thank you. I should perhaps just explain. Debs has sent her apologies. She's hoping to join us later, but speaking to Look North at the moment about the situation in schools and the revised advice we've given to schools regarding COVID. So It's understood. Excuse me. Yeah, Anna, do you want to?
I was just going to say, just in terms of, you know, a further example that we do know, one of the actions is around population health planning, and how do we make sure that we take the account of the needs of different communities into that planning process. So we've previously spoken at meetings that there's been significant work in our local system regarding how we understand inequalities experienced by people waiting for treatments. And we've made significant changes in the way that our priority around waiting lists and waiting times are now viewed, and the actions that we take. So as well as using, as we always have done, the clinical need to determine priority for treatment, we are actively using health inequalities data as well to make sure that we're not widening a gap in inequalities. And that's been noted, I think, within the region and nationally, as Calderdale really taking forward some thought leadership in relation to that, which is now being embedded into national guidance. So that's another example of very practical actions that have been taken.
Thank you, Anna. Okay, I'm not seeing anybody else coming on that, so can I ask that then that we agree the two things, to note and approve the process that's being taken, and to commit to making time for that slot on a future meeting to hear from community voices and experience. Everybody okay with that? I'm seeing nods and hands, so thank you very much. Thank you, Anna. So item 7 is supporting people with learning disabilities to live a larger life in Calderdale. And Sean, do I take it you're introducing this item?
Yes, thank you, Chair. I'll be introducing the item, and then Karen from our commissioning team and Glenn from our transition services will talk through the paper. Just to set the context, and just very briefly, the context is that since the pandemic began 18 months ago, we're all aware that the impact on people with learning disabilities has been great, really, and probably at times not been reported as much nationally as it could have been, really. But certainly in Calderdale, we've worked closely with providers and all partner colleagues, really, to make sure that in all aspects, and regardless of the person's level of learning disability, they have been supported to lead as full a life in constrained circumstances as much as possible. But they have been disproportionately impacted, and that has further impacted really on their scope, as it has for many people, in terms of moving into employment, which is a key driver for the council and all statutory partners, really, and to work with the business community. And we've always been a strong performer in that area. So the paper's going to outline the key initiatives that we have been working on in the past and that we're looking at in the future, to make sure that we are getting as many people in employment, because they're proportionately smaller than the wider work market, to make sure that we get them into sustainable and valued employment opportunities. And the request to the Health and Wellbeing Board is that this is supported, and that the commitment from each of the agencies in terms of what that will mean as far as placements are concerned, both temporary and longer term, is given by each of those organisations, including the council, of course. So if I hand over to Karen and Glenn, they'll talk you through the paper itself.
Morning everyone, it's Karen speaking. I'm the service manager for commissioning, contracts and quality within the local authority. Got a colleague here, as Sean said, Glenn Swindell, who works on a 5-day offer for people with a learning disability, and we've also got a colleague, Karen Graham, from the voluntary sector, who works for Cloverleaf on a project called Lead the Way, that supports lots of initiatives for people with a learning disability in Calderdale. As Sean's outlined, the pandemic has had a detrimental impact on people with a learning disability, both in Calderdale and nationally. And we brought a paper earlier at the beginning of 2021 regarding the health inequalities for people with a learning disability and the adverse impact that the pandemic had had on that. Health and Wellbeing Board asked us to look at a larger life for people with a learning disability, in addition to the health needs. And we've brought this paper today really to outline some of the initiatives in terms of employment and daytime opportunities, social opportunities, but also to ask Health and Wellbeing Board to think about the agencies they work for and their own employment policies and procedures and how supportive they are of people with a learning disability. So as the paper stated, our employment statistics have dropped to 4% of adults in Calderdale with a learning disability being in full or part-time employment, which is a pitiful figure really. We were at 8% prior to the pandemic. Again, that wasn't great, but we were a good performer and we've dropped by half during this period of 2 years. We all know the benefits of employment in terms of social advantages, financial advantages, and also the impact on health and well-being, people's confidence. We know that many young people in Calderdale aspire to employment, and Ravenscliffe School has worked closely with young people to ensure that they do have those aspirations and they support people in work placements, etc. But we don't always have the opportunities in the community once people leave school. We've done a little bit of work with Ravenscliffe and we've looked at the leavers figures over the next 10 years, and they are in some years going to quadruple from where they are now. So it's really important that we have those correct employment opportunities, pathways and support for people when they leave school, so that the work that Ravenscliffe has done and other education providers isn't lost and people have real opportunities. We also know that if paid employment is successful, it reduces dependency on formal services and leads to greater independence. So not is it only good for the person, but it's also good for ourselves as a commissioning organisation, because it means people have a lower dependency on long-term services. So as the paper's outlined, we have had lots of developments in Calderdale. I guess Project Search has been our flagship development over the last 4 years. That's for young people aged 18 to 25, and it's been a partnership between Calderdale College and the Foundation Trust. And that's been really successful in terms of internships and getting people into paid employment, not only in the hospital, but in local organisations. So it's paid dividends really for those young people who are now in secure paid employment. And we're looking at how sustainable that is as well, because also once someone's in employment with a learning disability, it isn't as straightforward as you or I getting a job. You know, there are long-term support implications to keep that person in a job. As I said, Glenn has worked in Calderdale now for a number of years and has established a 5-day offer, which saw a real reduction in the number of people requiring out-of-area placements. I think if I recall correctly, when Glenn came into post, there were 27 young people in out-of-authority residential colleges, which was both very expensive and disconnected people from the local area. And he's worked to develop a bespoke offer to link people to local community resources. We've turned around the offer at Calderdale College and also adult learning, and that's been a real benefit for Calderdale, keeping people locally so that they're not disconnected from Calderdale and encouraged to stay in long-term placements once they've ended their education. So in terms of Calderdale's approach, we're also beginning a pathway to a strategy, a multi-agency strategy, and Fiona Thirlbeck has been instrumental in establishing a working group around that. And there was a workshop last week bringing together colleagues from training, HR, adult social care, and from the voluntary sector to try and look at what pathways we've got, what opportunities there are, but also what gaps there are, so that we have a solid employment strategy that can address some of those gaps and ensure that we have got the appropriate opportunities in Calderdale, both for young people leaving school and for those people post 25 who are a little bit out of the education loop, but also have aspirations for employment. Alongside that, we've been trying to develop the larger life offer, So our community-based daytime opportunities tender that was recently launched has looked to have a more diverse offer. We know people are interested in arts, horticulture, music, and we haven't had those offers locally. So we've tried to work with external providers and bring them into Calderdale to make sure that we do have a wider offer and people aren't just offered the traditional day services. Sean's team is also reviewing our in-house offer as well, so that we can be centres of excellence in terms of daytime provision and have more employment opportunities internally. So the ask for Health and Wellbeing Board is, first of all, that you support the development of the strategy, particularly those colleagues who have key officers involved in the development of that strategy, that you support that and try and make those inroads within your own areas. For all partners across the Health and Wellbeing Board, that you examine your own workforces and look at how inclusive they are, how reflective are they of our local population, and what would it take for you to recruit and retain someone with a learning disability. We're not asking you to do that on your own. It might be that you think some professional support, someone like Lead the Way, and they've got expert by experience, could help with that. So we're also willing, you know, to take back those ideas around what we could do to make other employees more inclusive. We're asking people to think about job carving and internships as well, so more creative ways rather than just advertising jobs as they stand, and to think about supporting the proposal around a post-25 internship programme. So I guess just to conclude, really, within the paper, if you've had a chance to watch, we did embed Roy's story, who's someone with a learning disability who works for Lead the Way. And if you haven't had a chance to watch that, it's perhaps a good thing to reflect upon, because Roy outlines all of the things we've said, the benefits that employment brings to him in terms of his own confidence, well-being, his lack of reliance now on as much paid support. So I think Roy is a real good example of both what employment can do for a person with a learning disability, but also what people with a learning disability can offer to local employers. You know, that they're very loyal often, they don't leave jobs. They've got a whole load of skills that they can bring. So it's really a big ask of the Health and Wellbeing Board to support the employment of people with a learning disability and to think about your own policies and recruitment. So thank you, everyone.
Thanks very much, Karen. So a lot in there, both in the presentation and in the paper. I have a couple of comments myself in a moment. Adam, you've got your hand up.
Yeah, thank you, Karen. It's an important piece of work. I think the internship offer is a really good idea, and I think, you know, the council's got a really good strategy for offering opportunities to care leavers, and as a result, we've ended up with, you know, a number of care leavers who've gone on to work for the council. And I think if we can offer something similar to people with learning difficulties, I think that would be a real strength. I just wondered, though, whether we could go further and offer it to younger people as well, because 25 just seems like quite old, really, because, you know, often young people will get to the age of around 16 or maybe 17, 18 and start wondering what it is they want to go on to do for employment. So to wait to 25 just seems like, you know, you could spend 9 years out of education by that point, or 7 years, certainly. So I just wondered if perhaps whether we might look to extend that offer.
Thanks, Adam. Am I okay to come back on that, Chair?
Yes, of course. Yes, please.
Yeah. So I think, yeah, we'd be more than happy to extend it to younger people. I think the 25 idea was that there's a real gap because we have Project Search for 18 to 25-year-olds because it's funded by higher education. So people with an SEN plan are able to access Project Search. And we do get a cohort of people for that, but we feel that that meets at the moment the demand amongst that younger age group, and there's a real gap for the 25 plus age group who aren't able to access Project Search. Not to say that if we had a wider offer within statutory services that we wouldn't open it to people where it was appropriate under 25, but it was just really highlighting that there is nothing for that older age cohort where there is for people aged 18 to 25 with Project Search.
Thank you.
Thank you. Okay, so I've got a few questions now. Stephen?
Yes, thank you, Chair. Yeah, it's a great paper. And it's wonderful to have a focus on health and well-being that doesn't involve health checks and referral pathways and medicines and operations, but actually thinking about employment and opportunities and prosperity, because we know the impact that that has on someone's well-being, and life expectancy far outweighs what the health service can do. So it's a brilliant focus to have. But as you said, Karen, 8% wasn't great, and it's down to 4%. So I think what it might be useful, well, a lot of things would be useful, and I think all the points that you brought at the end of the paper, the suggestions, recommendations are good. What's the totality of the learning disability population? Has there been an assessment of the employability? And what's our aspiration? Is it to get to 10%, 20%, 25%? What are the best places in the country, best places in the world doing for their populations in terms of employability? I'm sure that Glenn can come in and help us with some of these questions. Have we had that local assessment? And then how clear are the pathways into employment? For, you know, we probably have at our own practice maybe 40 employees, but I don't have the first idea about how to access this cohort of the population and really see what the value. I'm sure that a person with learning disabilities at reception in a GP surgery could offer a completely new way of accessing the public, the care, the tenderness, the love, the compassion that they can show. And I think that the public would respond to that. So I think we're missing out on a treat by looking at 8s and 4%, and I think we should be aspiring to a much greater level. But I think there's, we need to systematize the flow in to both to education and keeping that education going. And Glenn's doing some great work. He's helped my own son. I should probably declare a slight interest, but he's helped my own family as well, a lot as Glenn. So there's some brilliant work going on, but we've got a long way to go on this.
Okay, I'll come back then in terms of the figures, and then perhaps I'll hand over to Glenn and Karen Graham from Lead the Way in terms of some of the blocks and things around the pathways. So in terms of figures, we've got an LD population of about 680 people in Calderdale who are known to us, and we've currently got 33 people in paid employment. So as you say, Stephen, it's very low. We're looking to the strategy to set a target. I would say some of the best performers, I think, in the past have been places like Lanarkshire that have got into the teens of percentage. No one's got perhaps beyond 15% to my knowledge, which again isn't great, but we could look to be at least the best in the north, I think, in Calderdale with the pathways and setup that we've got. Part of the paper was obviously, I know, like you said, it would be great to have someone with a learning disability in reception, and how great would that be for someone coming for an appointment with a learning disability to be greeted by someone else. But we know it's not easy for agencies to employ people. So part of it is an ask around what support would you require, and perhaps I'll hand over to Glenn and to Karen around some of the barriers really to employment, and particularly once people are in employment and support drops off.
Claire?
Yes, yeah, thank you for that. Hopefully you can hear me okay. I've got a slightly unstable internet connection, so if I break up, I'm sorry. Yeah, thank you, Karen, for all that information. I thought that was great, and thank you, Stephen, as well, for raising a few of those issues. Yeah, this is it's a complex area, and there aren't easy answers, but the fact that within the Health and Wellbeing Board, there's so many people taking an interest has really helped this year and galvanised people from different agencies to, get the shoulder to the wheel to move things on. Data is something that we do lack in terms of, you know, people who've got jobs. That isn't something that's routinely captured. So that's something that we want to get better at. And that's going to be part of the strategy is making sure that we know how many people have got jobs. So we know how many people perhaps want jobs, and getting those percentages of people who are in employment up is absolutely vital. So I was only chatting with Fiona Thirlbeck last week about adding some targets into the strategy so that we can obviously measure how far we've come. I think we can make some big gains within the council and other statutory sectors in terms of the numbers of people that we employ. And Stephen, you're right in saying that it can be confusing as to what pathway people take. If it's confusing for you, well, it's confusing for me, and I work in this area. So within the strategy, making sure that we can make it far easier for people to see what is available and how they access that support. And we can do that. That isn't a problem. That just needs breaking down. And one of the things that we've thought about is possibly using ISCAL within the council as a gateway, because of the expertise that we have there with Fiona and Audrey. And obviously we've also got Project Search at the hospital. So we've got some quite strong brands that hopefully people are now aware of. And we can use them for people to certainly come into the council and then get them the appropriate help to possibly have an internship, possibly have a supported apprenticeship, with the whole idea being that will lead to paid employment within the council. I'm passionate about the council becoming a real leader in the area, and we can then show off basically what we've done and how we've helped people, and then hopefully we can get more private sector employers on board. And as Karen said, you know, the benefits of employing someone with a learning disability are many, which is what keeps me going in this job, because I love helping people grow and develop and seeing what they can bring to organisations. I think that's probably enough from me for now.
Could I just come in there? Hiya, it's Karen Graham. I work for Cloverleaf Advocacy, and my colleague Tracy's here as well. As an employer who employs people with lived experience of learning disability, the benefits, the positive benefits are absolutely massive. And, you know, I could talk all morning about employing people with learning disabilities, but I think from an employer's point of view, we looked at reasonable adjustments, so how we advertised specific roles to people, the application process, and how we interviewed people. We really did that on a person-centred approach. So we looked at those reasonable adjustments and how we could make it easier for people with learning disabilities and other disabilities to actually apply for some of these roles. So that really did help people. The benefits to us as an organisation is, I don't have a learning disability, so how can I say what some of the difficulties and what some of the barriers might be? We've got to listen to people with lived experience, and they're the ones to guide us and as an organisation. But just when Roy started with us 4 years ago, he lacked in confidence, and now 4 years on, he's really good at planning. He organises and facilitates events himself, and he doesn't use services as much as, and like as Karen Midgley said, you know, it's about reducing the need to access service providers and to be able to do things more independently. I'm just going to bring Tracy in if Tracy wants anything.
Well, yeah, I'd like to add also, we have done some focusing on the pathways into work, and we've identified that needs to happen earlier. So when people are doing careers advice at school, there needs to be a clear pathway from identifying what you might want to do. So we've got clear data to plan for the next 4 years, ready for them to access work at 18. And it's not very clear, that pathway at the moment. We'd like to make that pathway better and also more person-centred.
Thanks, Tracy. Okay, come to Megan next.
Yeah, it has gone. Thank you, Chair. This morning I was reminded about, you know, how people cope sometimes, because on Facebook, my goddaughter there, and she's 39-year-old, and she's got very, very severe Down syndrome. You know, at one point, nobody would get anywhere near that. Now, she doesn't live in Calderdale, and her work pattern has never been really good. You know, she'd have a few weeks doing a day at college in the canteen and then in a shop and one thing and another. So, you know, anything that can be done to get the take up more can only be good. I mean, Ravenscliffe are fantastic, which is why we supported them getting the sixth form. And there's a lot of good work along with this report going on. But sorry about the but, everybody. I have to tell you, I'm scandalised at 4%. You know, we've talked about all these people on one thing or another, and I know how difficult it is, but it's not going to be any easier to get them and help them next week than it was last. So I've also, sorry, and then I'll shut up, Chair. Walking around the town, the number of shops and other places that have got, you know, vacancy things in the window. You know, perhaps if when somebody connected is walking past these things, they make some sort of note. It might be something that shop has never thought about. But when somebody actually mentions it to them, you never know, do you? Right, I finished.
Thanks. Is it okay if I take 2 or 3 comments for people to come back on at this point? It's got 3 or 4 to come in. So we'll go to Helen next and then Sean.
Thank you. I'm mindful of how important this work is around opportunities for people with learning disabilities, because of what was said about the figures in terms of the increasing number of people who are living in Calderdale, who will be of working age, who will be sort of leaving school and kind of being available to be in the workplace, but who perhaps wouldn't have those opportunities at the moment. And I keep thinking about what we've been talking about percentages and what would be a suitable percentage. Actually, if there's a really significant increase in the number of people, that becomes an even bigger challenge. So I just think that there's something for me about us understanding sort of as a health and wellbeing board as well. So there's something really important about this work around people having increased opportunities. It's also something really important for us to think about as a health and wellbeing board, if there are an increasing number of people living in Calderdale who have learning disabilities, and how accessible our services are for people with that lived experience. And I just think that there's something really pertinent about us understanding that picture and how accessible Calderdale is as a place for people with learning disabilities, as well as a place that offers great opportunities to people with learning disabilities.
Thank you, Helen. Can I come to Sean next?
Yeah, thank you, Councillor Swift. Just briefly, really, just for more context, having worked in other local authorities in other places, to echo what Helen just said there, the conditions to create opportunities for people with learning disabilities are really significant. The potential is there, and the aspirations across all of the provider partner agencies, really, in one way or the other. And not to be technical in any way, but as far as the stats are concerned, that is, in terms of the 4 and what was 8%, those are for people in receipt of care and support from the council in one way or the other. And we do have to think about the wider, including this group, which is absolutely crucial, but the wider group of people that don't receive support, that have a degree of learning disabilities across the borough too. So they are incorporated into this whole discussion. In 2007, the then government released a whole programme and a strategy called Valuing Employment Now. Some colleagues might remember that. And the ambition was, just in terms of the question from Stephen to Karen, was to get 15% of people with learning disabilities into employment by 2015. And then the world kind of stopped as far as the recession was concerned, and it was seen as, then it was disbanded as a programme. So there's so much more scope to go for with this. And I think actually the opportunities coming out of COVID and the way that our job market has just changed beyond recognition, really, the employment market nationally actually gives us some real opportunities with employers right across the piece to really take this agenda on in the way that colleagues have highlighted today. So I think, if anything, we can really move this agenda on with the delivery plan that we're working on.
Thank you, Sean. Yes, that point occurred to me on a couple of those, and Megan's point about retail and so on, retail, hospitality, horticulture. These are all areas that have got real employment challenges now as well, aren't they? Caroline.
Thank you, Chair. Just really to come back on Stephen's point specifically about primary care as employers. I mean, the challenges that what small businesses, small employers need to support people with learning disability into roles is very different to the larger employers. And so that's one of the things that we're actually working on as a group across the system. And GP practices are an obvious starting point, which we've obviously clocked, and we are actively working through what the pathway and the support needed would be to make sure that we can support people with learning disability to be working in those sorts of environments appropriately, and then to publicise and actually get that actually in place. And just one quick thing on the data is, yes, it's not accurate, and it is horrifying, Megan, I completely agree, but it is something that isn't captured. So we know that nationally it's the same for all data. Benchmarking is the same. So with the way we benchmark is pertinent. So the fact that we are only ever managed to get up to 8%, but the national top goal was sort of, or gold standard at the time was 15%, does reflect that we are perhaps halfway up to where we might want it to be, or we were before the pandemic. But it's another stream of work is to actually get some realistic data on not just paid employment, but it's actually meaningful occupation for people, because those who can't necessarily at this point cope with paid employment can certainly start the process towards that by being meaningfully occupied first of all. So the whole picture is what we're considering.
Thank you very much. I think a really good range of views and perspectives there. Karen, is there any final points you want to come back on?
Yeah, I guess so. The points Megan raised about the wider community, definitely we do need to make those connections. We did at one point have a board that sat under Project Search to look at wider employment opportunities, and perhaps that's something the strategy can address again. And we have got Fiona leading from Inclusive Economy, so she's the right person to do that and to bring in those wider employers outside of the statutory employment. The point Helen makes about school leavers, yeah, we are really carefully thinking about those growing numbers and having the right opportunities, and the wider accessibility. Not only will they need employment, but they'll need homes, accessible leisure, etc. So I guess I just wanted to highlight people that we do have a learning disability partnership board that meets bi-monthly, that lead the way, organise, and we have a lot of representatives from that. So that if that is something that people are interested in, learning about the wider learning disability agenda and some of the work that's ongoing around wider accessibility and issues for people with a learning disability, Lead the Way and Karen Graham are your connections for that. Back to what Sean said, yeah, we really need to set those targets and make sure that strategy creates those opportunities for people. And some of the issues around collecting data we are trying to address, because it isn't something that's contained within our client information system. It's a trawl to our providers and known people. So sometimes people are missed in terms of collecting that data. So we do need to get smarter at that. And just a thank you to Caroline, really, who always on any agenda item for people with a learning disability. She's always there at the forefront, trying to make inroads and create opportunities. So the work that's going on in terms of primary care, if that can be brought to the forefront, then that will be a great example and you know, set the benchmark really for other people. So thank you, Caroline.
Okay, thank you everyone for the contributions on that. I think clear from what was said, I think there's endorsement for the 7 actions that were set out there. I'll just double check that for you people at the end, but really to reinforce that people follow up on those opportunities. I've certainly thought of some things as this is going on that from a council perspective, I think we can take and look forward. So people happy to receive that report and endorse the 7 actions? Yes, I'm seeing a good range of nods and approval. So thank you very much, everybody, and thank you, Karen and colleagues, for that presentation. Next item 8, the Health and Care Bill and the various strategies. Just bear with me whilst I find the right introduction to the paper. And do I assume that Rachel, is it Rachel that's introducing this? Yes. It's hard to find people on screens, isn't it? You keep moving around. So Rachel, if I can hand over to you to introduce this one. Thank you.
Excellent, thanks, Chair. I have got a set of slides, which was the paper that was circulated around. So if everyone's happy, I'll share those to talk through as we go. I've got a message saying I don't think I can screen share. Is someone able to enable that?
Yeah, hi Rachel. I'm just allowing it now. So if you can go in now, it should work.
Yeah, perfect. Thank you, Fazana.
No worries.
So good morning, everyone. For those of you who don't know me, I'm Rachel Bevan. I'm working as a programme manager in Calderdale to support place-based partnership development. So I'm here today to give a bit of an update to the Health and Wellbeing Board around the implementation of the Health and Care Bill in West Yorkshire and more importantly in Calderdale. So I'll run through these slides by way of the update. So as many people will be aware, back in February, the Department of Health and Social Care released a white paper in which there were intentions outlined to establish integrated care systems on a statutory basis from the 1st of April next year, so 2022. In establishing those integrated care systems in that new way, each integrated care system will comprise both an integrated care partnership, so building on the partnership boards that are already out in the systems at the moment, and an integrated care board. The latter will be responsible for taking on the commissioning functions of CCGs as they currently stand, so clinical commissioning groups, and the integrated care partnership will be responsible for developing the strategy for the whole of West Yorkshire, which both the integrated care board, local authorities and others will need to have regard to as they plan their own strategies and develop work. So in terms of what's happening in West Yorkshire, so there's a range of work taking place at the moment, lots of activities going on in preparation for if that bill passes and the new arrangements do come in the 1st of April. So a few outline timescales there, but a lot of the work at the moment is around working out exactly what that integrated care board and the integrated care partnership are going to look like. The integrated care board is going to be a new organisation, so needs to be fully constituted as such. So there's a raft of work at the moment around developing that constitution using the national template that has come out for that. There's also a lot of work around recruiting to senior roles, so things like the chair for the integrated care board and the chief exec, along with a number of executive and non-executive roles and other members of that board as well. So a lot going on at the moment, and it's important to note that those arrangements are being developed in parallel to what we're doing in Calderdale. And similarly, nationally, there are still bits of guidance coming out, still new things being developed nationally, although we are starting to get a bit clearer on a lot of the answers now. But really important to emphasise that a lot of this is very ambiguous still, and we're still working through a lot of the detail. So you can see in the timelines there set out a number of activities to undertake. So again, around those appointments, around the constitution, around making sure that West Yorkshire as a whole system is ready to move to those new arrangements ahead of April. And then if the legislation passes as proposed, then the Integrated Care Board would be established on the 1st of April next year. So what does this mean for Calderdale? So we know in the white paper it spoke about the statutory integrated care systems, but a really key part of that as well was emphasising the need for place-based collaboration. So when I say place, in this instance, I mean Calderdale. In most areas, a place will be defined as a particular local authority area or a borough, although that there may be some exceptions to that, but that's largely the rule. And certainly in West Yorkshire, there are the 5 places based around the local authority and CCG footprints. So off the back of that, each of the 5 places within West Yorkshire are further developing their arrangements that they've got at the moment. So these next few pages are what I'm going to describe around what we're doing for that in Calderdale. So I think important here just to step back a little bit and reflect on the fact that collaborative working and partnership working across different health and care organisations in Calderdale isn't something new. It's been happening for a number of years now. Back in 2018, there was the concept of Calderdale Cares that came up. So at that point, that was a model for integrated health care and wellbeing. And that's where we started to really formalise some of those ways of working. And you can see the original aim set out on the right there. So better wellbeing for all, seamless services that for those that need help, and harnessing the strengths of Calderdale's people and communities. And then the model around that was partners working together to make that happen. So you can see there that, you know, this is, again, it's really not the beginning of working together in Calderdale. And those aims still very much ring true today. We've also had the pandemic, which clearly we're still working through. But again, that's just another example of how organisations and services have come together to really tackle things jointly and, again, move forward in that partnership way of working. So where we are now is just a continuation of that. It's nothing substantially different. The main thing is that rather than referring to Calderdale Cares as a model for health and care, we're now referring to Calderdale Cares as the Calderdale Cares Partnership. So those health and care organisations coming together as a partnership under the banner of Calderdale Cares. So moving forward in that way, making sure that Calderdale is ready for the new arrangements coming into place in April 2022, which I'll just go into a little bit more detail on in a moment, working through what those arrangements might look like. And again, just thinking about, much as this isn't the beginning of collaborative working in Calderdale, then the end of March next year, the start of April next year is similarly not the end of it. This is just one part of that continuing journey. The partnership will continue to develop, services will continue to develop, everything will continue to develop beyond that point. So in preparing for April 2022, there are some things that we know that we have to do to make sure that Calderdale is ready. So in establishing the Integrated Care Board, if that comes into place on the 1st of April, that Integrated Care Board will assume the functions of all 5 of the clinical commissioning groups currently within West Yorkshire. Under the principle of subsidiarity, it's expected that the majority of those functions will be delegated back down to place level, so to Calderdale, to Kirklees, to Wakefield, and so on. But given that the CCGs will stand down as the Integrated Care Board stands up, we need to make sure in Calderdale that we have got somewhere to receive those delegated functions, because we won't have the CCG arrangements in place anymore. So what we're looking at the moment is how we achieve that, and we're looking at having a Calderdale Cares Partnership Board. So that will be officially a committee of the Integrated Care Board, and that's going to be a similar arrangement across the 5 different places in the West Yorkshire footprint. So things will be delegated down from the Integrated Care Board down to the Calderdale Cares Partnership Board, and then we would hope that that board would be in a position to both influence and be accountable back to the Integrated Care Board. Both of those boards will be decision taking. They're both things where formal meetings will be held in public, and they're both things where at the moment there are a lot of discussions around who should sit on those boards. So what will the membership be? What will the chairing arrangements be? What will the different rights of different members on those groups be? How will they actually operate in practice? So all of that is a very live debate at the moment. And again, slightly tricky given that both arrangements are being developed in parallel, whilst we're also still getting national guidance at the same time. So that's the kind of must do on what we definitely need to make sure we're ready for in terms of April next year. But alongside that, we're also thinking about what other opportunities in moving forward with the Calderdale Cares partnership we could actually progress. So are there things that we want to add into the system where we think value could be added? What else have we already got that's really working very well? So, for example, we know, here is a classic example, we're all sat here in the Health and Wellbeing Board. We know that Health and Wellbeing Boards are going to remain as key parts of places within the new structures, and that is very much the case within Calderdale. So an outline there of currently what the Health and Wellbeing Board does, but also really, I think, emphasising that in setting that strategy, the health and wellbeing strategy for Calderdale, thinking about that relationship between this board and the Calderdale Cares Partnership Board, and in terms of making sure that the small service element of delivering the health and wellbeing strategy is taking place, and understanding how that's happening for Calderdale. Similarly, whilst we'll have the partnership, the statutory organisations involved in that will still retain their own organisational governance. People will still retain their own statutory responsibilities. So again, building on that as well. But then there are elements where we've had discussions and thought actually there are some opportunities here about how we can bolster what is happening in Calderdale and to help build in some more elements. So, for example, we've got a number of instances of clinical and professional leadership listed throughout the entire partnership and the model. But what we agreed is that there would also be value in setting up a clinical and professional forums, that sort of formal leadership element for Calderdale, feeding into the Calderdale Cares Partnership Board. So we've had a few meetings of that group now, and that's chaired by Dr. Cleesby, who's on the call today, and a few others who are on the call today are also involved in that as well. Similarly, we've got a number of instances where our experts in communications, engagement and equalities are coming together. So thinking about how we can maybe do that once rather than multiple times. Thinking about where are we really utilising the learning from those different groups of people. So where we've got messages coming from the public, how can we really strengthen those and share those across each other rather than duplicating work or having to do things more than once. And similarly, where there are really important messages that all partners across the partnership want to share, how can we distribute those effectively and make sure that we're doing that in a consistent way? And then additionally, there's an element of, whilst the Integrated Care Board will be accountable for a lot of what will take place through the Calderdale Cares Partnership Board, we still want to make sure that really important matters, so things like quality and safety, are still on our radar for Calderdale, and that we've still got a set of joint priorities for the partnership. We've still got an understanding of exactly how we're delivering outcomes for patients in our population, what those quality measures are, and making sure that we've still got oversight of that. So thinking about what we need to put in place there, given that some of the arrangements currently via the CCG won't be there from the start of April next year. And then finally, we've got a couple of things I think it probably spans across both of these headings. So things that we've already got in place, but also what else we could be doing. So just thinking about what else we need or what else might be of value to make sure that we do keep delivering outcomes for our population. So, for example, thinking about how our providers work together across Calderdale. So we've got a number of instances of that already. We've got a collaborative around community providers, but is there value in doing something more than that, something that spans all providers in Calderdale? So just thinking through those sorts of things, and not to be making this a real industry of infrastructure, but thinking about what will bring the best value to Calderdale, what is really going to enable us to deliver what we need to for our population. So just the final slide now. So as I've said, a lot of this is still in development. It's a lot of things we're still working through, but we know that we want, whatever the arrangements, final arrangements look like, we know that we want to make sure that they are all of these things. So making sure that they are transparent, that we've got things held in public where we need to, amongst other mechanisms, that everything's got a clear purpose. So actually going back and challenging ourselves to say, well, we thought this might be a good idea, but actually now that we've done a bit more thinking, we've reviewed it, maybe this isn't actually adding anything new, or it is a duplication of something else. Making sure that shared principles, values and behaviours are embedded throughout everything. So things like trust and respect and integrity and resilience and many other things like that that are embedded throughout the structure. Making sure that we effectively manage conflicts of interest and putting in mechanisms for those. So in a number of instances, things will already be in place for that, but for the Integrated Care Board Committee, how are we going to achieve that? Similarly, making sure that everything we do has got the option to be independently challenged and scrutinised. So again, making sure that that's built in through the model. And again, everything that's got clear accountability and we know who is responsible for what, how things are reported to where. That all our delivery infrastructure focuses on outcomes. So again, just bringing that back to what is this particular arrangement going to do to support providing outcomes for our population and moving things forward. And then also making sure that both as we develop the current arrangements, but then also as we move forward and think about what else we might need, or as we progress programmes of work, that things are shaped by our experts. So that's both our experts by experience and our professional experts as well. So that's just a bit of an update on where I've got up to so far. I'll stop sharing my screen. Very happy to take any questions.
Dr. Cleesby, have you seen that Councillor Swift has lost the internet? So could you take the chair, please?
Is Stephen there as well? I don't think, I can't.
Stephen's struggling as well.
Oh.
I can give it a go.
Yeah, Councillor Fenton Glynn, can you step in just to take questions? Thank you.
No worries, thanks for that. I'm just having a quick look. I don't see, oh, hang on, I'll go for Ashley first, if that's okay. Councillor Evans, sorry, and you're on mute, I'm afraid.
Sorry about that. In the meeting and don't switch my mic on when I need to, my apologies. Clearly, this is a major move in the right direction. We've all been aware of the need to get much more coordination across the whole. And it's impressive to have the various boards being set up, and I recognise the clinical and professional forum and looking at the different aspects of it that were raised. I suppose my concern, if you will, is how we will ensure that providers work together at an operational level. I suppose it is the operational bit and the boards and the forums and so on are very important. But I think we need to be sure that the various mechanisms are in place to enable the various contributors to all of this to work effectively together. Clearly, we've been doing some of that already with Calderdale and so on, but I wonder if there are going to be plans put in place to enable and encourage that connection between the various people at an operational level. Thank you.
Yeah, I think that's going to be a real challenge. Do you have an immediate response to that, or is
I don't, but I think Robin might want to come in on that one.
Yeah. Thanks, Chair. I think the first thing to say is that just building on what Rachel said, this is complex. This can feel quite remote. It can feel quite laden with jargon and technical language. I think we're trying our best to minimise that. What we need to remember is that for the most of the time, in nearly all situations, both direct health and care provision and the context and circumstances that lead to people to be well and live good lives happens in place, happens where you live, happens in your street, happens in your household, and happens related to your friends, your family, and the work you do. So I think we should not worry too much about a lot of this, but recognise that the model of how it's being provided is shifting in terms of the West Yorkshire context. Operationally, there's work on governance, which is just trying to make sure that there's not only a place-based partnership at a strategic level, but that we can do thinking, that we can do doing together as best we can. So there's a collaborative, I'm not even going to try to describe the community services term for the name of the board. People are smiling because I can't stand it, but it's loads of C's anyway. But there is a group that actually is thinking about how we collaborate around community services, which is going to continue in a new format. That's going to be a really important place. There's still going to be informal networks around not only all partners, but building on the relationship with particularly primary care networks, which have a real place in localities in terms of supporting hubs and localities working together through primary care. So all of that will still happen. We just need to fully describe that. And of course, all of the things that retain a political accountability and oversight of health and care will continue. And I think in some ways this board becomes even more important because it becomes the key strategic voice for Calderdale to influence the West Yorkshire system. So we will want to work on the role of this board, and as well as the role of other forums for elected members like scrutiny, both in Calderdale, but joint scrutiny. So all of that will still exist. And I think if anything, it'll be even more important because we are going to have at times a need to articulate and shout our voice because not everything will shift, but some decisions will need to take place at a West Yorkshire level that may have in the past happened purely in Calderdale. Thank you.
Okay. Thank you, Robin. Helen, I think you were next.
Thank you. There's just a couple of comments that I wanted to make, and I've been involved in the development group for this week. I think the thing that's really important from my perspective as somebody who's kind of here to represent sort of public voice is that it will be very easy at this point in time with so much pressure to get caught up in the governance arrangements that we need to have in place to make sure that we work in an effective way. And I'm not saying that that's not important, but actually I think there's some really great opportunity that comes from us working in sort of shoring up our integrated ways of working. And I think that what Calderdale is really good at is identifying some of those sort of strategic ambitions that we have and that we jointly hold, and working together toward those. So I think there's something that's really pertinent and important in terms of what is being developed at the moment about keeping those principles at the heart of it and creating governance that facilitates what we want to achieve for our people and for our place. And I do feel like that is the direction of travel that we are moving in, and really important to keep that in mind as we get closer and closer to the deadlines when things have to have been officially done and as new bits of national guidance come in as and when they do. The thing that's really important from my perspective is stuff around accountability. And I don't think particularly, and I could be wrong, I think there'll be a cohort of people in our population who are concerned about accountability in the very traditional sense of our meetings in public. Is this information available and transparent and all of that kind of thing? And that's absolutely necessary. But accountability to the public is much bigger than that. And I think that is very much about being able to evidence being true to those principles that we have set for ourselves, and people being able to see how our system and our services are adapting and changing in a way that makes it better for them. So I think there's something really important for us in that kind of accountability piece about being able to tell a really easy to understand but compelling story about how better integrated working is improving the way that health and care services are provided for our population, and facilitates us to think about that ambition of everybody having a larger life.
Thank you. Yeah, that's important. I'm going to hand the baton back to Tim at this point, I think, and let you come in if that's okay.
Thanks.
So, Councillor Swift, I beg your pardon.
No, well, I tend to run this fairly informally. Thanks. I hope my my Wi-Fi doesn't disappear again. But yeah, actually, Helen just said a number of the things I was going to say about the balance between it's important you get the governance right, and actually it's easier to get the governance right when things are going well, and those are the times when you don't need it. It's when things go wrong you need the governance to be in place, and that's not the time to fix it. So it's always a balance, I think. But I think what we're trying to do in structure is capture how we want to work, the way in which we want to work, the expectations we have, we work as a partnership. We own problems collectively. We take decisions in a way that recognises the impact that what we do as one part of the system has on other parts, and we don't do things that harm other parts of the system without talking to them first and understanding what the implications are going to be, etc., etc. For me, those are the principles that we're trying to capture in the governance. And I endorse what Robin said. Whatever the formal structure said, the Health and Wellbeing Board at the heart is the place where we talk about the big issues that matter to Calderdale and Calderdale's voice, and that won't change. And I think the other thing to emphasise is there's a shared view both at West Yorkshire level and at Calderdale that we want to drive this process of change by saying, as far as we can, what is it we want to do? What is it that works in us? And let's make the national guidance work for us rather than wait to be told by the national guidance what does there. That of course is always challenging, and we know there's more to come down the line. We talk about white papers on both social care and integration to come as well, but I hope that's the approach we can keep taking. Are there any other questions or comments on this paper? Okay, thank you very much for that update, Rachel. And obviously this will keep being a regular report to this meeting. Thank you. Okay, so item 9 is the homelessness and rough sleeping strategy. And apologies, I've slightly lost track of. Heidi, this will be you, I imagine. So over to you. Thank you.
It is. Thank you, Councillor Swift. Good morning, everybody. For those people that don't know me, I'm Heidi Waters, and I lead on housing and green economy for Calderdale Council, and homelessness and rough sleeping sits within my service area. Also here this morning is my colleague Nicola Kaiser-Forrest, who leads our homelessness service for us. The first thing I'd like to say about the report that's presented in the homelessness strategy itself is that it's very much a partnership piece of work. One of the things that we recognise in homelessness and rough sleeping is that the sole solution is not just putting a roof over somebody's head, although that often is a great start and foundation to work from, but really to support someone who is or has experienced homelessness or rough sleeping. It's about all the other wraparound services that somebody needs, and that partnership approach is essential to delivering those services. So we have a wide range of organisations and partners that work with us, from health colleagues in the CCG and SWIFT through to services within the council, public health, adult services, etc., but also external partners from the voluntary and community sector, providers who directly provide services, and also colleagues from Together Housing as well. And that group have helped to develop the action plan, but also they are the people that monitor and review it and make sure that things happen. There are 4 themes that we have within the action plan itself. Some are cross-cutting. We have prevention, which is really key and important to working with those that are at risk or potentially going to be homeless, because if we can prevent homelessness, it makes a world of difference to people's lives. So that's a really key theme for us. And then we have intervention and recovery as well. But what I thought I would do this morning is focus more on progress, where we've got to thus far, and also plans for the coming winter. It's already starting to get cold, and it's going to get worse. So I just thought I'd update people on that as well. One of the things that I think is really important to mention up front in terms of progress is to talk about the links that our work has with the Burnt Bridges work. I know the Health and Wellbeing Board have been involved in that work, and it's really important for me to let you know that the findings and learning from burnt bridges informs our work, both in terms of what we do currently, but also our plans for the future. And that's really helped us to build and develop what we want to do on this agenda. So some of the things that are in place, we have been working for some time on a project called Making Every Adult Matter, MEME, and that's really helped in terms of focusing our work around individuals, some of those people that are the most complex, have multiple needs, and have often sort of slipped through gaps in services. We now have very regular meetings, both with frontline officers, but also senior officers, to make sure that we can identify what needs to be done to support those individuals. And it's really made a difference because we have input from across services, and that commitment has really made a difference to the changes that we can make to people's lives. We've developed a pathway as a result of this joint working. Previously, we really didn't have a firm response for people who were rough sleeping or had multiple and complex needs. But now we have a really clear pathway starting at the very front line in terms of the resource that people can access through a service called Number 42, which is in the town centre. So for those people who really need an immediate response in terms of being homeless or sleeping rough, they can access support either through Number 42, where we have or will have a range of people working there. So it isn't just housing workers, but we'll have, for example, people from our recovery services based there. But we also have an outreach team as well, both officers from the council, but also from our partner agencies who are being proactive and going out onto the streets of Calderdale to identify anyone that might need our assistance. The next step would be we've developed an intensive support service for people who are ready to move into some kind of accommodation. It's very supported, it's 24/7 support. And then from there, we've been able to develop accommodations in 17 different units of accommodation for sort of move on from that intensive support. And people don't have to follow the pathway in that way. They can access different points along the way dependent on what their needs are. We've been really successful in bidding both as a local authority, but also in partnership with other partners for funding for different pieces of work. So the projects I've just spoken about at Craven Mount and Next Steps were funded through central government funding. But we have also got funding to support a range of different residents who might have specific needs. So that includes people who are ex-offenders or leaving prison and need additional support to access accommodation, and working very closely with partners from probation and other agencies that work with these people. And we also have somebody who is going to be a specialist in working with people with debt and finance issues, because we recognise with the pandemic that will be a challenge for many people. And we also have a tenancy liaison officer. And amongst other things, they'll be working with private landlords, because I think sometimes landlords see the council as somebody that sort of comes and challenges them over things, when actually we want to be able to support them and provide them with advice and help, hopefully, to prevent people becoming homeless at the end of the day. So we've been successful there. One of the big pieces of work we had was to look at how we developed a psychologically informed environment, a place that people could feel safe and didn't have to keep telling their story about their experiences. And that has been something that is an ongoing piece of work, but Craven Mount is one example of where that is starting to happen. We also have the gathering place, which is where the winter shelter, the night shelter operates from. We have a wound clinic that operates from there. And we're also being able to access some training for staff around psychologically informed work, trauma-based work, and understanding how to be able to effectively support this client group. And then finally, just in terms of our winter response, for many years in Calderdale, we've taken a slightly different approach to the advice that is given around cold weather. The advice is that if it's going to be below 0 degrees for 3 or more consecutive nights, then you would provide accommodation for anybody. So even if it's somebody that isn't entitled to accommodation, for example, people with no recourse to public funds, we can provide them accommodation in those circumstances. However, in Calderdale, we take the stance that if it's 0 degrees for one night, that should elicit a response from us, and that is what we do. So if during the next coming months it goes below 0, or it's forecast to go below 0, we will be offering our emergency cold weather accommodation during that time. To enable that to happen, we work closely with the winter shelter. Normally that would be open from October, but we have been able to work with them to get some funding to do some building work that will ensure that we've moved from a dormitory style provision to individual bedrooms for residents, which really is something that we should be providing. And so it does mean this year there will be a delay, but that doesn't, in terms of the opening date, that will be in December this year. But the local authority are stepping in, and we have made provision to ensure that if somebody does need support, they will receive it. And we've got some additional accommodation available to us to make that happen. But hopefully when the winter shelter does open in December, it will be an improved service for the residents that use it. So I think that's all I had to say this morning. Quite happy to take any questions. Thank you.
Thanks very much, Heidi. So we asked for this to come here following the Burnt Bridges report, and I guess particularly the focus for the Health and Wellbeing Board is to be sure that we're getting the interagency cooperation and support and actions right on this. Ashley.
Thank you, Chair. Yes, I was involved to a certain extent with the Burnt Bridges report and reviews of that, and it's the critical issue which came out of that for me was the previously the lack of integration of services, and it's good to hear this is central to this work, and thank you for that, Heidi, in terms of a good informative presentation along those lines. Couple of questions. You made specific reference to a term making every adult matter. The young people become homeless also. I wonder where they fit in this situation. I'm sure you can come back on that one. And there was also a reference to outreach, which is good to hear, because I think one of the problems before was that you tend to assume, well, the services are there, people can come and make use of them and introduce themselves to the service, but so often the people who are in these situations can't, don't, won't, are unable to, don't know where or how, and therefore I think the outreach is a critical part of this development, which I'm very pleased to see. And the third point I wanted to refer to was a sort of little bit of advertising in a way. I chair the S&P Scrutiny Committee. In fact, this afternoon we're starting our working party on debt and finance issues, on problem debt and finance issues, which again I think Heidi referred to, that the issue of debt leading to homelessness and so on. That's something we're looking into in great detail, and perhaps we should coordinate on that in terms of what comes out of our work and what you're doing with yours, Heidi. Thanks very much, Chair.
Are you okay for me to come back, Councillor Swift? Thank you. So whilst MEME is about adults, it's very much about looking at systems as well as individuals. in terms of working with young people who are 16 and 17 and therefore not classed as adults, we have a very specific separate service, and we have very clear statutory responsibilities to young people of that age group. So I very much see that the work of MEME will benefit those young people who are homeless. But I think probably we are further ahead with some of the work that we do with our young people, because we have spent a number of years working really closely with our children and young people's services to try and join up the work that we do around that cohort. So there's already a real raft of support for those who are 16 and 17. But that doesn't mean that if we did have somebody that we felt could benefit from the MEME framework, that we could look at taking that to that group of people if it was needed. In terms of outreach, just to reassure you, it's not just the traditional kind of workers that go out. So yes, we have somebody from the council's housing team that is part of the outreach response. We have somebody who goes, or a number of people that go out from our provider, Horton Housing, who do a great job doing outreach, but also other parts of the council who are out and about and seeing people. So a really good example are the street wardens from Derek Ben's Community Safety Service, who often can develop a really positive relationship with individuals who are on the street, and we share knowledge and understanding between us. So it isn't just about the housing response, it's much broader than that. And then in terms of the work you're doing around debt and finance, absolutely we'd like to join that up. We do sit on the anti-poverty working group that is chaired by Sarah Richardson, and actually our officer will be attending one of those meetings in the near future. But yes, we really want to ensure that we benefit from any of the work that you're doing on your scrutiny committee. So yeah, thank you for making us aware of that.
Thank you. And just to note, Helen's put a link to the MEME approach website in the chat for those who haven't seen it. Josh.
Yeah, we had a really useful event on this on Tuesday, actually, looking at the progress of the burnt bridges, kind of the response to the burnt bridges report. And I think actually, your point is well taken about young people. Obviously, they're not in the same group and looked after in the same way because we've got different responsibilities to them. But actually, adults on the street don't come from nowhere, and that's why the trauma-informed approach that we're taking is really key to how we respond to this. I think one of the things that I think is kind of has been spoken about a bit and is kind of referred to in the paper, which I think I'd just like to underline, is the kind of the multi-agency approach when we get in touch with the people who are at the greatest risk. And actually, it's been really good to see how many different agencies have stepped up. So, I'm not going to talk about individual cases, but there was, when there is someone who people know is in need of being supported by those services, they may come in for something, some very immediate treatment, but there are things around which make sure that they then get passed on, and we're not putting the onus on the individuals, and often individuals who've got somewhat chaotic lives to jump through hoops. And I think that's, if there's anything that you can learn from some of the stories in Burnt Bridges, then it is that, the harder you make it for people to get that help, the more likely they are to slip through the cracks. But also what I'm keen to do is just put out there on record that we are, this is a learning process. And I said this at the review the other day, I think Mike Tyson said everyone's got a plan until they get punched in the face. And it's that kind of, we've all got a plan until it meets with reality. So we don't expect to get everything right at the moment. And if I heard that we were getting everything right, then I would worry that we weren't hearing everything. So this is a long iterative process, and the more voices and the more views and the more experience we get, then the better we hopefully will be at responding to this.
Thanks very much, Josh. So that's probably the first time we had Mike Tyson quoted at a Health and Wellbeing Board meeting. Any other questions or comments? Heidi, any final points you want to respond to?
I'd just perhaps like to finish on a point that Councillor Fenton Glynn made. I think often it's easy to have empathy for children and young people who've experienced trauma. It hits us right in the heart, and you know, we want to make sure that we support them. We see them as a victim and somebody that needs help, and we wrap around everything to make that happen. And something seems to happen at the age of 18 where suddenly those children are offenders, they're causing a problem, they're seen very negatively by the community, and we forget about the trauma that those people will have gone through throughout their lives. And that's one thing that Burnt Bridges really brought home to me, the significant trauma that some of our residents have gone through. And turning 18 doesn't change that. It doesn't change the experiences that they've had in their lives. And that's why this work is so important. And I would just like to thank every single agency and service that are on this call, who have been involved in the work around both Burnt Bridges and our homelessness and rough sleeping strategy, because we couldn't do this without their input and support. So thank you very much.
Thank you, Heidi, and we'll make sure that's minuted. Robin.
Yeah, I just want to echo Heidi's comments. I think really well observed. I mean, just the ability, unfortunately, for society to suddenly deem an individual conducting similar behaviour on their 18th birthday as being a perpetrator rather than a victim, and the way that actually services can struggle to respond to that, but just generally that the way that people are somehow seen to somehow be adults when they wake up on their 18th birthday. And we know probably from personal experience as well as in our families that isn't actually always the case. In fact, often usually isn't. So the way we put that wrap around is really important, and it's system thinking, a bit like it's already in children and families, is key. Just finally, I know we haven't got time to really discuss this, but I just want to put on record thanks to Heidi and her team, and also dealing with a really significant issue that has health and wellbeing impacts around asylum and migration, and just sort of to make you aware as a board that we are working really proactively on that issue. We are actively part of the Afghan resettlement program, the ARAP program that it already exists and has done since the spring, and the new citizen resettlement program, and we are accommodating our first families, and we are working to support their health and well-being. And I'm sure we might want to come back to that at a future meeting, but just to sort of thank Heidi and the team for responding so quickly to what is a complex issue, as we did before with the Syrian refugees as well. Thank you.
Thanks, Robin. Again, I endorse that. Thank you. Okay, so we're happy to receive that. Thank you for that presentation, and note the ongoing actions. And that brings us on then to item 10, an age-friendly borough. And I have to admit, I've slightly lost track of who's presenting this item. So
it's Ken Barnsley, if he's here, Chair.
Right, I can't see Ken on the call at the moment. No. I don't think I've got everybody on one screen.
Councillor Swift, I'm not sure where Ken is, but I think between Ian and I, if we needed to, I think we could probably present this if Ken's having. He might well be having IT problems. I think a few of us are who are on the system today. But in the meantime, I'll try and text him. But I don't know if it's worth us trying, Councillor Swift, to present this in Ken's absence.
Yeah, if that's okay, I think that would be good. Yeah.
Don't know, Ian. Do you want how do you want to do this? Do you want me to, or?
Debs, I'm not on the call at the moment. I've been substituting for him today, and I haven't seen this paper, but I'm happy to contribute and go through it.
Yeah, Ian's there. I can see Ian. Yeah.
Okay. Sorry.
Ian's
sorry.
on mute.
Yeah. Sorry. Apologies. I'm having some problems with my internet connection as well. So the paper that Ken has produced for us is based on a broad commitment around becoming an age-friendly borough, and there are some core recommendations that we're asking the Health and Wellbeing Board and the respective partners to consider. So as a council, we are keen to approve the policy objectives that are set out in the World Health Organization's age-friendly community. And also as a council, we are committing to becoming part of the network of age-friendly communities across the UK. And that we are committed to sign up to the Ageing Better statements. So I think as a council, we have put some commitment into becoming age-friendly. Cabinet in particular have got a key priority about becoming an age-friendly borough. And one of the reasons for bringing this to the Health and Wellbeing Board is for the Health and Wellbeing Board to have sight on the ambition of becoming age-friendly, but also to recognise that there may be things that we will need to do collectively to ensure that we create an inclusive community where people can grow old, have active participation, and kind of recognising that the breadth of what we do in Calderdale and how it impacts on people. So this is it's obviously brought on behalf of adult services and public health, but it's to recognise that things, for example, like planning around spatial development, around planning for transport, are the things that can actually exclude older people as being making a valuable contribution to their communities. So I think hopefully people will have had a chance to review the paper. And I wonder whether it's just worth us having a debate about the principles of being an age-friendly community and how Health and Wellbeing Board can support that overarching ambition about driving the priority forward.
Thanks, Ian. Debs, is there anything you want to add to that?
Yeah, please. Thank you, Councillor Swift. I think that's a really good suggestion from me. And I think just the other thing to say is that one of the key elements of the work that's been done in preparation for us developing our work on age friendly is some appreciative inquiry with older people themselves to really understand what being an age friendly Calderdale means to older people in the borough. And that's really important. That's using some of the existing community engagement assets we have, but actually asking people in a positive way what makes Calderdale age friendly now, and what more could be done to make it age friendly. And then finally, just to say that as part of the work, it does say in the paper that the idea is that we'll set up an age friendly alliance that will bring people together to sort of coordinate the work that we do, but also stimulate and inspire further action in communities and with wider partners for the borough to be age friendly.
Thanks, Debs, and clearly that's one of the reasons for bringing it here, because this only makes sense if we have buy-in from key partners. Josh, I'll come to you.
Yeah, I mean, I think just sort of building on that thing about the Age Friendly Alliance, actually the key thing is that although an age-friendly culture and borough is key to the well-being of older people, we shouldn't see it only as a health delivery system, because actually it's about allowing people to live lives that are more fulfilling as they get older, not, and that will have positive health outcomes, but that's not only delivered through health services. So I think that's going to be key. And, you know, when we talk about this, we have to always make clear that that's the case. And one of the things that, you know, we want to do with this the Age Friendly Alliance is make sure that we're hearing across the council how our actions impact older people. So, I mean, I spoke to Val Stevens from Hebden Lloyd Town Council this morning, who I suspect I'll be hearing quite a lot from about the kind of the plans as we form them. And she was talking about some of the funds that they've set aside for benches, and you know, we've got the town plans and the local plan, and they're going to involve some significant building, and we have to think about within our physical architecture and design of our streets, what we're doing to make sure that people who are a bit older are able to be are able to walk, are able to have space, you know, have got kind of age-friendly sizes of communities, and, you know, whether that be benches or whether that be lighting, or, you know, whether that be activities that are going on otherwise. So yeah, it's absolutely right that this is a health and wellbeing board, but it needs to be spread across the council like like cheap perfume. So that's what I hope to achieve.
Thanks, Josh. Ian, you want to come back on?
Yeah, I mean, thanks to Deb, because I think I probably did miss the most important part of what this is about, which is actually really co-producing with older people what they would like for their lives in Calderdale. And I think it is far-reaching. Josh is right, Councillor Fenton-Glynn's right, is that really what this is about is, it isn't just about health, it isn't just about social care, it's about the cultural life that older people want to see themselves. And we've been having some conversations with the group of people who are working on the cultural strategy. And one of the things we want the cultural strategy to do is for older people to see themselves in the cultural strategy, so they can recognise themselves, but also that they can actively participate in cultural life. And I think occasionally in our thinking, we can inadvertently be age negative. And actually what we want to do is recognise that older people have got great experiences to contribute to our kind of public life, and we want to make sure that we don't put barriers in the way to make that happen. So it will be very much about the voice of older people, and scarily now, I think we're talking about older people in the age of 50 plus. So somebody that's just had their 60th birthday. I really want a place where I can actually actively participate in public life. So I think it's something that hopefully we can all get behind.
Thanks, Ian. I probably shouldn't mention the age profile of councillors. Helen.
Couple of things that I wanted to mention. First and foremost, I feel like the age-friendly borough stuff fits really neatly and sweetly with what we've talked about in terms of a priority in the joint health and wellbeing strategy around kind of connectivity for older people. And I think that's a really important thing for us to, as a health and wellbeing board, be keeping an eye on, to be looking at how that age-friendly borough work helps us to achieve that objective of ensuring that people who are older have connection with their community. So I think there's something that's really important in our role around kind of making sure that takes place. I think something, and this is perhaps something that I feel quite personally quite strongly about in terms of older people, is that I feel like often when we talk about older people and we talk about their health and well-being, we mean that in the context of their physical health and well-being. And often you find that older people who perhaps are experiencing challenges with their mental health or mental well-being don't necessarily seek or receive the same support for some of that low mood or anxiety that they might be experiencing, because it isn't seen as part of an older person's set of experiences in terms of mental well-being. So I think there's something really important for us when we're talking about kind of connection and interaction, in thinking about how that supports older people to maintain better mental well-being, as well as that kind of physical activity and getting out there and doing things. I think there's something really significant about capturing perhaps the impact that COVID may well have had on older people who have been isolated, perhaps much more than other cohorts in society, and the mental impact that that might have had for those people.
Thank you, Helen. Stephen.
Thank you, Chair. I think actually Helen said everything I wanted to say, so probably not much point in just repeating that. But yeah, we've got connectivity to the Calderdale Cares, to the refreshed wellbeing strategy that we decided on a few, I think 2 or 3 priorities for each area, didn't we? And at the time, I was thinking, well, what does it actually mean in practice? How are we actually going to do that? And this seems like the obvious thing to be doing to achieve the aims of the wellbeing strategy. So it's bringing it to life for me, and is definitely something that we need to be accepting. If there's a choice whether we do this or don't, to me, there's no choice. We just have to get on with it and bring it to reality. Yeah.
Thank you, Megan. You're on mute.
I know that's what I was looking for it. Thank you very much, Chair. A quick comment. I don't know why, but you know, when you're old from 55, or you're referred to as an old person, I take exception, and I'm sure a lot of other older people take exception. I don't want to go to something that only old people go to. I can't wait till I get in a residential home and sit in community room. You know, there's got to be things organised that if older people want to use, they can use and be comfortable. But, you know, we haven't got the greasy spoon in the market that only somebody over 55 can use. I hope we haven't anyway. That's my point. Thanks, Chair.
Thanks. Josh.
Yeah, I just want to reassure Councillor Mrs. Swift. The aim of this is not to have services that are for older people. It's just to make sure that our services are thinking about older people and kind of aware of those things. And actually, sometimes, you know, you tend to find with tasks like this that actually, if you get some of those cases better for a certain group of people because you're being aware of them, they actually end up being better for everyone. And hopefully that's we're going to see more of those things. And, you know, there are the specific things, you know, the kind of the Dementia Centre of Excellence and stuff that look at it from a health point of view. But the stuff that looks at it from a social point of view is very much about trying to just make people feel able to be included. And the idea is that people are included in society, not that we have a separate society hived off. You know, that's why we want to make our town centres more vibrant for everyone who wants to use them, and not make them have transport that gets in the way of people being able to access them. So please be assured, we want to do the exact opposite. And obviously, we know that 55 is still young, whatever the definition of old might be, or older might be. And I'm going to stop talking before I get in trouble.
My experience with age concern is that older is 10 years older than whatever age you happen to be, even if you're 85, even if you're not. Ashley.
Thank you, Chair. I think I have to start by declaring an interest in this, being a white-haired person. Surely there can't be many people 10 years older than me, but there we go. It's very important, obviously, forgetting the clever comments. Just one question, one thought, one observation. I note that the World Health Organization has set up a network of age-friendly cities. We're not a city, clearly. But I note, just been doing a little bit of research there, that Leeds is one of those cities, and I'm wondering whether we ought to be linking up through Wicker with Leeds in terms of the age friendliness, and whether as a an area we should be working together on these things. Just a thought.
Thanks. Thanks, Ashley. It's certainly something we can pick up. Okay. Any other comments? So can I take it that the council's commitment to age friendly is something that has wider support from our partners and endorsements. Yes, I'm seeing plenty of nods for that. So thank you very much, colleagues. Right, we're nearly out of time, but well on with the agenda as well. Item 11, COVID update by exception. I just wonder, perhaps, Debs, could I just perhaps ask you to do a very quick headline, and perhaps those that haven't picked up, just highlight specifically what we're saying about schools and why?
Yeah, of course, Councillor Swift. It's good timing, isn't it? Actually, in terms of the timing of the board. So yeah, just to let board members know that the current situation in terms of COVID cases in Calderdale is actually the highest it's ever been throughout the pandemic, and actually. The evidence is pretty clear that the high number of cases is being driven by transmission in school. And cases in school-age children have never been as high. But in the most recent sort of weeks, we've actually seen the virus being passed from school-age children and young people to older age groups. And we have actually the 5th highest case rate in people aged 60 plus in England. And of course, we all know, don't we, that the vaccine weakens the link between the high numbers of cases and serious illnesses, and it hasn't broken it all together. And actually, the case rates in people aged 60 plus is actually the biggest predictor of need for hospital care. And we are now, unfortunately, seeing increasing numbers of people needing hospital care. That is compounded by business continuity challenges, because staff that work in NHS and care services, a number of them are off either because they've got COVID themselves or because they're caring for the school age family members that are absent from school, and that's further sort of creating a challenge. So because of that, and because the evidence is pretty clear, actually, that almost all the cases of COVID in Calderdale, people are coming into contact with the virus either at school or at home. Because of that, we've made some recommendations to schools yesterday. We wrote to all schools yesterday and all parents yesterday, asking schools to consider taking a number of extra measures. So I'll just quickly summarise what they are. So anybody who's had somebody with COVID in the home will know how hard it is to prevent it spreading to other family members. So the first thing that we're asking is that where someone in the home has tested positive for COVID, any children and young people who live with them actually stay away from school for 3 to 5 days and then get a PCR test. And obviously, if that test is negative, then the child returns to school. But obviously, they must stay at home and arrange a test if either their test is negative or they get symptoms. In addition to that, we're asking schools to think about recommending more use of face coverings, ventilation, reducing mixing between groups, limiting visitors, and thinking about whether residential education visits should go ahead. And just finally, Councillor Swift, just to say that these schools know their communities best, and they may choose not to follow all of these recommendations, all of this advice. Their decision that they make will be based on their own circumstances, the infection rates in school and in the local area, and the impact that COVID's had previously in their local community. So that's a summary, Councillor Swift, of the recommendations that we've made.
Thanks very much, Deb. It's helpful to highlight that. You've touched also on the pressures in the NHS. Is there anything any other partners want to highlight at the moment about health pressures? I don't know, Ian, from the point of view of the Urgent Care Board, whether there's anything you want to add?
Thank you, Councillor Swift. Obviously, we have been doing quite a lot of work to prepare for winter, and Deb quite rightly points out that the number of people in hospital is increasing with COVID. We've also got a significant number of people in ICU. I think what we're probably experiencing is some of the things we thought we would be planning for winter are actually happening now. And as a system, we are looking to ensure that we can assist with the flow through hospital, but there are significant workforce challenges and on-day demand pressures at every pinch point of the health and social care system. So it's going to be a very challenging period, I think, into and through winter. Our original assumptions we've been planning on in terms of the number of people on the transfer of care list going into winter is we're hoping that there would be no more than 74 people waiting for a transfer of care. Currently, we're in excess of 74 and we're not yet in winter. So the work that we're doing as a system is going to be critical. We are also asking for some additional support and resources from the West Yorkshire and Harrogate system, just to help us think through how we might approach that. So we have got contingency plans in place, but it's going to be very stretched. And as Deb also points out rightly, that with the significance of the increasing number of people over 60 being exposed again to COVID, even with high rates of vaccination, it's weakening the link, it's not broken the link. So we are seeing some issues that we'll need to continue to work with our social care providers in terms of ensuring that outbreaks are kept to a minimum. I hope that helps.
Yeah, thank you, Ian. Caroline.
Just a quick point that one of the major issues to me still seems to be that people believe that doing a lateral flow test once they've got any symptoms at all is still the right thing to be doing and will authoritatively state they've had a COVID test and it's negative. And I just still think that the messaging is just not right out there. Plus also people's interpretation of what the symptoms are is often very rigid and goes by the original 3 symptoms, whereas we know now that there's a lot broader range of symptoms. So I just think and I know we're trying our hardest, but I just think some really clear messaging about lateral flow tests are not tests for COVID would be really helpful.
Thanks, Caroline. Robin?
Yeah, I think that message just still hasn't been heard about the tests. I just want to sort of talk about just briefly. I think Ian's highlighted really I think we've got to be really careful about not talking about this just as the pressures in the NHS. I think and Ian's points about the pressures in domiciliary care in particular is a national problem, and it was I think it was a bit depressing. I think the chair of ADAS spotted that yesterday morning it was the main news. And by the evening, it became social care trying its best to help the NHS. That this systemic, fundamental core issue about people requiring domiciliary care. That's one point. Second point, and we're getting into it too much, is the money helps, but the idea that any money injection, as announced this morning, is going to make a difference to the challenge in primary care is fundamentally naive, and it worries me about the level of understanding at a national level of what's actually happening in primary care, because it's not clearly understood if people are thinking that's the solution. There aren't the locums out there, the people out there for nursing, for community services. We're in a bidding war to try and get support and workforce. The biggest crisis now is workforce. You can have all the money in the world, but people can only do so much, and primary care is pretty much on its knees. So, I mean, Dr. Taylor and Cleese, you want to say anything about that, but I mean, you can't just keep asking the same people to do more locum work. So I just want to just highlight that we're in for some unprecedented challenges because we've got flu and COVID this winter. It's really important to remember we didn't have that last year. Thank you.
Thanks very much. Ian, you want to come back? Ian, you're on mute.
Apologies, sorry. I was hopefully going to get through a meeting without talking about the social care workforce crisis, but Robin's given me such an important in that it would be rude not to run with it. Yesterday, Skills for Care, which is the Sector Skills Council for England, released its State of Social Care report, which is an annual report that it does. And on top of the existing 110, 112,000 vacancies in social care across the UK, they're also predicting that in order to meet future care requirements, we will require another 400,000 people to move into social care. So there is a supply issue. There's an issue at the moment, I think, that we have to address, which I think is about money, but it's a national issue, is that in order to slow the stem of people leaving social care, we need to be able to compete with other sectors that are either paying better hourly rates or holding enhancements to stay in the sector. Because I think the challenge of the future supply is a big one, and that's not going to be resolved overnight. That needs long-term planning and investment, and we need a 10-year plan like the people plan for the NHS to enable that to happen. But we do have to find a way of just stemming the flow of people leaving the service that have committed themselves to the pandemic but are really tired, but then are having to deal with issues of either having to take the decision to move out of care, which they really value, because they need to put food on the table. And I think it would be amiss of us not to recognise that there are far too many people who work in social care who are still reliant on universal credit, and that we do need to fundamentally address the value that we place on social care.
Thanks very much, Ian. Wholly endorse that. Debs.
Which is just one final point, really, Councillor Swift. So I think the timing of the extra measures that we've asked schools to consider is really important. We really want to try and do everything we can to get the situation under better control now, for three reasons. One, because we're not yet in winter, and we want to sort of prevent further challenges to services in the winter. Secondly, because of we want to those who want the vaccine in school, those 12 to 15-year-olds that want the vaccine, it's really important as many kids as possible are in school to get it when the vaccination team arrive. And then finally, I'm also really conscious that we're heading into half term, which potentially gives us a little bit of a break in terms of transmission as well. So I just wanted to explain a little bit about the timing.
Thanks, Debs. And I noticed exchanging that you said you'll send some shared messages about why people shouldn't depend on lateral flow tests if they've got symptoms and so on. Helen.
Sorry, I've stuck my hand up at the last moment. It was just to respond because there's something in the chat as well about the pressure that staff are under and how fraught lots of providers are at the moment, and I think that we're in a bit of a perfect storm with it, where actually members of the public who we are talking to are feeling really frustrated by the ongoing pandemic, by the fact that there might have been delays in their care experience, and actually that means that they enter into interactions with health and care providers in a much more distressed state than they might have done previously, but that actually then the staff who are receiving that more distressed interaction are also themselves under a lot more strain and a lot more pressure. And actually it's creating, I think, a lot of the feedback that we are getting about kind of people's negative experiences, I think is completely understandable in all directions, because everybody is functioning at in a place where they are much more stressed and perhaps less able and less resilient than they were prior to the pandemic. So I just think that there's something really important for us in our messaging about that kind of mutual respect between provider organisations and members of the public, and the need for people to approach services in a way that is understanding and services to reciprocate in the same way.
Thanks, Helen. Okay, and some useful comments in the chat and thoughts there, and thank you for the link to that thank you video, Steve, Neil, as well. And perhaps we can send that out to people, perhaps in case anyone's missed it as well. Okay, thank you. I'm not seeing any other hands, so that's just for information and update. So the final item is the forward plan for next time, which has been circulated. Mike, is there anything to add on that?
Very briefly, Chair, it's a bit of a long list, but there's the agenda setting meetings on the 11th of November, and I think we'll have to whittle that down to make it a more realistic list for the December meeting. The 11th of November is also the next date for the informal development, health and wellbeing session. Currently on the list is the revised health and wellbeing strategy that Debs is leading a group working on. We've also got age friendly on that list. Having had a bit of a discussion this morning, I'm wondering whether we actually need to focus on the health and wellbeing strategy at the informal health and wellbeing board, but I'm meeting again with Debs in about 50 minutes, so I'll discuss that with her and bring it into the agenda setting meeting. Thank you, Chair.
That's fine. Any other questions or comments? Okay, happy to let the agenda setting group make sure we have a sensible meeting. Okay, thank you very much everybody for your time this morning. Covered an awful lot of different issues, and wish you all well.